Hi guys, welcome to X-ray files for fluoroscopy. We'll go ahead and get started right away. So this first image that we're going to see is of the large intestine. So you can see, I don't know, it's hard to see, it's a little dark, but there's pelvis down here. So here's your rectum, your cecum going up to your descending, your flexure would be up there. But right here in the kind of transverse colon area in the right flexure, you can really see all of this inflammation here. This is colitis. So colitis is inflammation of the colon. If left untreated, colitis can lead to ulcers, which can be very painful to the patient. But you can see here that the intestine's distended. You can see kind of the mottled appearance, which is the inflammation. And it can also be an infection. This right here is appendicitis. So there's some other things going on here. You can see some really air-filled dilated loops. They might have an obstruction as well. But right down here is where the appendix is. This is the cecum. And you can see here that there's appendicitis. So a lot of times with appendicitis, the definition is inflammation of the appendix. But a lot of times you can see signs of inflammation, you can see fat saturation, or sometimes the thickening of the walls, which can lead to appendicitis. It's really important for that to be diagnosed properly because if the appendix ruptures, it can cause a lot of severe damage and the patient can become septic. Well, this is endometriosis. So a lot of people know of endometriosis in the uterus, but they don't really know as much about it in the intestines. But endometriosis is just abnormal growth of the endometrial tissue that's in the lining of the intestines. And what it actually does is it penetrates the wall of the intestine. So you can see kind of right here how it goes in. This is where endometriosis has affected that lining right there. This is a picture of colon cancer, and a lot of times this type of colon cancer is referred to, the sign of it is an apple core lesion. And if you kind of look here where this kind of comes down and here, it does really look like an apple core. So this is a good indicator of colon cancer. And you can see here what the image would look like on the inside. So there's these masses that are growing in the colon on each side, and what it's doing is it's creating a stricture or narrowing of the large intestine here, so it can cause blockages and things like that where the patient can't get things to pass. It is, cancerous. However, if the cancer hasn't spread yet, a lot of times what they can do is perform surgery and remove the damaged portion or the unhealthy portion of the colon, and then resect it together. And like I said, if the cancer hasn't spread, that can help save the patient. This is an image of diverticulum. So this is a double contrast study, and again, we can see the air and fluid levels, right? See how this is a nice flat line, horizontal line here of the contrast that's settled down and the air's risen up. This patient is standing upright, I can tell just by that image. But remember, normally the intestines has that nice smooth border on the edge, kind of like this here. But if you look at this person, see all these little round, like, pockets or outpouchings? There's one down here. So these are diverticulum. These are outpouchings in the lining of the intestine. So a weak spot happens to kind of pouch out. The problem with this is when we eat things like seeds or nuts or popcorn or even cucumbers with those little seeds in there, what happens is as that food is traveling along, it can get stuck out here in one of those outpouchings, and it stays out there. And it doesn't just kind of wash out like everything else that we eat or drink does. So it can help, or it can cause inflammation, it can cause infections, and when that happens, it's called diverticulitis, which is inflammation of the diverticulum. It's very painful. I don't know if any of you have it or know someone that has it. It is fairly common, but it can be very painful. Worst case scenario, they can lead to, again, like some of the sections of the colon being removed and resected. So I don't know if any of you can tell what's going on here. So this is an IVP. We called it a limited IVP because we weren't able to get everything. But I'm not sure if you guys can tell what's going on here, what this is. I know this picture's just a little bit blurry, and I'm sorry, but this is a actual, oh, I guess I didn't even realize it set it up here. Sorry, I gave it away. But this is a pregnant woman for her IVP. I guess I should take that off if I want to actually ask that question. So you can see here the head's down, and you can see the spinal column here on the baby. Like I said before, you know, we will perform procedures on women who are pregnant if it's absolutely necessary. You can actually see, look at how the bladder is kind of smushed down here from the head putting pressure on it. But obviously this needed to be done. This woman's got an obstruction. So you can see here, this is what a normal IVP looks like. You can see the kidney and the renal pelvis, the contrast, and then you've got the ureter coming down. But there's a lot of overflow contrast in here, and the ureter on this side is very thick, which means something, maybe it's the baby, maybe it's something medical, but it's pinching that. It's not allowing the contrast to flow down into the bladder. So it's pooling up in the kidneys and the ureter there. It's a big difference in the size of this ureter than this one here. This is what we call BPH, a benign prostate hypertrophy. So what happens is if the prostate becomes enlarged, then it can put pressure on the bladder, which causes pain. It can also cause difficulty urinating. So if a patient has difficulty urinating, a man, then that's one of the first things that they want to check to see if the prostate's enlarged, which is causing pressure on that bladder. So normally the bladder would be more of a, you know, round oval shape here, but it's causing it to push up. I think this image is blurry again too, I'm really sorry. So this is a double collecting system. So what happens is this is actually a congenital defect. It's one of the most common congenital defects in the renal system. It can cause infection, and it can cause reflux, which is when the urine flows back up out of the bladder into the ureters. And it can also be a cause of obstruction as well. Alright, this is a double ureter. So you've got two ureters here side by side. I know, like I said it before, it's hard to see that, but this ureter is actually really good. You can follow it all the way down into the bladder here. This is an image of a couple kidney stones. So there's a big stone here inside the renal pelvis of the kidney. And then you've got another one over here. These stones are actually very large in size. I mean, these would not be able to be passed on their own. The patient would have to go to surgery. They do this procedure called lithotripsy. If you've never heard of it, what it is they take a laser and they go right in and they laser the stone, which breaks it up into a bunch of very small particles so the patient can pass it on their own. If they can't do that, what they'll do is use what they call the basket technique, and they hold the stone and pull it out manually. This patient has a lot of little stones, so you can see one here, here, here. There's a bunch of stones throughout. A lot of people can have stones and not know it. I don't know if you've ever had kidney stones before. I've had them twice, and I tell people all the time, that is, if a man's had kidney stones, that is a very close comparison to having a baby. I've had 3 babies with no drugs, and I've had 2 kidney stones, and I truly think having the baby was easier. Kidney stones are very painful. And mine was tiny, actually. This is a laceration from an MVA. So you can see here how all this contrast is contained inside of the kidney. You can see nice sharp lines here. Over here you can see where the outline is, and then how it's starting to flow out of the kidney here, kind of almost like into a blob. That kidney was lacerated, and the contrast has flown out during the procedure. So this is what I'm talking about when I said for some of the procedures, you know, when we use barium, if it would seep out into the abdominal cavity. With this, using the iodine, it's going to be okay because it'll be absorbed by the body. This is a horseshoe kidney, so these are what our normal kidneys look like. and the kidney, ureter, bladder. A horseshoe kidney is when they essentially grow together in the shape of a horseshoe. It affects about 1 in 500 people. If someone has a horseshoe kidney, it actually increases their risk for a kidney tumor. And they also have to be very careful for trauma incidents because it can rupture or have other injuries from that. This is what it looks like on the x-ray. It's not as easy to see, but you can kind of see here how they form together with the contrast. So you'll see those every once in a while. This is the esophagus with barium in it, so the patient's drinking it. You can see the barium here. There's a little bit of a stricture here. So this patient has dysphagia. Does anybody know what dysphagia means? It actually means difficulty swallowing, which is very common for patients that have an esophagram done. So we're looking to see if there's any strictures or reflux or something that would cause them to have that kind of difficulty swallowing. This is Barrett's esophagus, so you can see the arrow here and here is pointing to that. Barrett's esophagus is damage to the lower portion of the esophagus. It usually happens, right here's where the esophagus meets the stomach, so this is how we can tell it's the lower part. But a lot of times Barrett's esophagus is from chronic acid reflux. What it does is it causes abnormal changes within the mucosal lining of the esophagus. And if it's left untreated, it can actually lead to esophageal cancer. So it's really important if you have reflux, especially chronic reflux, to try to control that and to make sure that you're following up with your doctor. This patient actually has barium leaking from their esophagus. You can see here, it's nice and smooth lines coming down. And then once you get to right about here, this barium, it's just a very small leak, but it's leaking out of the esophagus. So if they used barium sulfate on this patient and not gastrografin, that patient would probably have to go into surgery and have that cleaned out, depending on how much it was. But there could have been, this could be from a disease or injury. I'm not really sure what the cause of that rupture was. This is a Bezoar. I don't know if any of you have ever heard of a Bezoar, but a Bezoar is a tightly packed, partially, it can either be undigested or digested material. A lot of times it's made up of maybe food fibers. Sometimes it's made up of hair and clothing fibers. So I know you probably heard people saying like, oh, I ate my twin. Sometimes they can even have like hair and teeth inside of them. And a lot of people used to say that it was the twin that they absorbed. But if you know any girls, or maybe you did, always chewed on their hair, pieces of hair can go down there, and our body's not meant to digest that. So sometimes it will stay in a form and it will pick up other things too. Like if you know, people that kind of suck and chew on their clothing or their hair, it can form these Bezoars. Most of them are benign. They don't usually tend to be cancerous. If it's not causing problems, a lot of times they won't do anything with them. It just depends on the location, the severity, and what's going on. This is a hiatal hernia. So a hiatal hernia is where the stomach, so remember, if you can remember what the stomach looked like on images earlier. So right about here, the stomach is actually pushing up through the diaphragm and like kind of pushing into the chest. So treatments can vary. I mean, with these, sometimes people don't even realize they have hiatal hernia. Sometimes it's not causing any pain or issues. Sometimes they're completely surprised when we find them on fluoro procedures. Sometimes medicine can be a treatment. You can treat it with drugs. You can leave them be, and sometimes they'll go back on their own, or if they're not causing problems. And then sometimes the patient will need surgery. It's just going to depend on each individual case. This is a barium study that they were doing, and the patient actually aspirated the barium. So instead of it going down the esophagus, it went down the trachea into the airway. So these are all the bronchioles of the airway. So like the roots, like of a tree kind of. So with this patient and the next one here, this is also an aspiration, so you can kind of see how it's that barium is coating the airway. This is going to cause someone to cough frequently. I mean, it's, if you've ever had something go down the wrong tube, you kind of know that feeling, and it's going to be even worse because of the barium. So a lot of times they'll have to go in and do a bronchoscopy, which is a procedure that will actually go into the lungs and suck that barium back out. Here again is a small bowel exam, so you've got stomach and then the small intestine. This is an image of a speech swallow study. So I told you guys earlier, when you do a speech swallow, you're working with a speech pathologist. A lot of times they're trying to determine what types of food that the patient can eat, whether it be thick or thin, or if they have to tilt their head a certain way when they eat. So what we do is there's someone controlling the monitor here, or the fluoroscopy machine, and we can watch it live here. And we feed the patient different consistencies. So it can be a drink, it can be, sometimes we put barium on peaches or graham crackers or cottage cheese, things like that. And we have the patient eat it and we watch them eat. You can see them chew and swallow. And what we're watching for is if that patient aspirates any of that during the exam. Now, if they do aspirate, it's very small portions, so it's usually not enough to where that patient would need a bronchoscopy. But these are fairly common, especially in patients who've had a stroke, so they've lost some of that motor function. They can see if there's ways that they can eat, or they can say, you know what, you need to thicken all your food. Anything that's thin, you're going to aspirate, so you need to thicken it, or vice versa. This is kind of what the image looks like. These are usually live images. I know this is a still, but like you can see the mouth moving, you can see him chewing and swallowing it down. This is an image of an arthrogram. So an arthrogram, like I said earlier, can be done to inject steroids or pain medicine into the joint space, or it can be done to put contrast in the joint prior to an MRI scan. So this is a completely sterile procedure. The radiologist performs this. We have the entire tray set up. They use iodine cleaning area, or actually it's called ChloroPrep now. Actually, it's a alcohol-based sterilizing agent. So they're going to clean off the entire skin, and then they lay this blue drape over it. This is all completely sterile. The radiologist has sterile gloves on, and they're going to inject a spinal needle, which is just a long needle, right into the joint space. Once they get all the way down to the joint space, they are going to put a little bit of contrast or x-ray dye in there to help verify that they're in the joint space, and then they'll inject either the steroid for pain or the contrast for MRI. And this is kind of a close-up of what it would look like as they're putting the needle in. Patients don't love these. They're actually fairly quick, fairly easy. They're not super painful. They use a lot of lidocaine, so it helps numb the area. They feel a little twinge when they get right through the joint, but other than that, most patients leave thinking it was better than they thought it was going to be. This is an image of a hip arthrogram. So you can see here the needle and the tubing coming in. They positioned it right in the joint space, and they put that contrast in to verify that it's in the joint space. And we can always tell that on the hip by, I call it the ring of Saturn. So that contrast is going to form a ring around the head of the femur if it's actually in the joint space. And again, here's one on the shoulder. See the difference? So contrast normally looks white. However, like I said before, they can invert the image to make the contrast look black. Most of the time that's radiologist preference. So here you can see that this contrast is lining the joint, and it'll again wrap around the shoulder like a ring. This is a hysterosalpingogram. So these start out just like you're having a pap smear. They use a speculum, they go in, and what they do is they inject contrast into the uterus. And what they're trying to see is if there's a blockage going to either one of the fallopian tubes. So here's the right fallopian tube, and you can see contrast in it, and the left. So this patient does not have a blockage. These procedures can be done for a couple different reasons. If a woman has been trying to have a baby and is unsuccessful, this is one of the steps to make sure there's not a blockage or something going on. They can tell even if one fallopian tube's open, then there's still a chance of them being able to have a baby. The other reason that we do them is for sterilization procedures. So if the tubes have been tied or other procedures that they do to block them off, we'll put the contrast in to make sure that it's not flowing to the fallopian tubes, to make sure that the sterilization worked. And last but not least is a defagram. So remember earlier when I talked about these, so it's exactly what it sounds like. There's almost like a little toilet seat here. You've got the fluoro machine standing upright with the monitor and all that so you can get everything ready. You're going to inject contrast into the rectum, so we fill the rectum up as full as you can get it. And then what you're going to do is have that patient sit on that toilet seat and bear down like they're having a bowel movement. We're looking to see, they're measuring here for the anus. They're looking to see how things are operating, if the muscles are loose and tightening properly, and what's going on with that function. So just for fun, this is a little radiologist photobomb, kind of just to end things on a light note. If you have any questions or concerns, feel free to reach out to me, and I will post these online.